Hi everyone. I thank the organizers for giving the opportunity to speak on such a important topic, which is basically an overlap between the cardiac practice and diabetic practice. Many a times nowadays we call diabetes as a cardiac disease also, because invariably people will die because of their heart related issues rather than any other cardiac complication. So I'll be talking on two very important things which needs to be addressed, especially in patient who have got a diabetics, and in Indian scenario we are all familiar with metabolic syndrome, where the management of hypertension and dyslipidemia is of paramount importance to prevent this patient from going to further complication. So these are two huge topics. I will try to be very brief and try to speak on the latest guidelines which are there and which are very relevant for our day-to-day practice, and the key points which have basically been improved upon compared to previous guidelines. So just a customary epidemiologic data. Almost 50% of adults in US have hypertension, but very few, 20% or less than them, in both male and female, have it. If you look at the Indian data, almost 20 to 35% all across various region will have hypertension. And there was a study by, it's not in fact a study, it is basically an initiative which is called India Hypertension Control Initiative by the Ministry of Health and Family Welfare, ICMR, WHO, and all combined. They enrolled around 4 lakh patients and 40 lakh patients, sorry. And what they found is that uh, because of this initiative, the initial control which they found in these patients were only a meager 2%. And over a period of time, when they enforced all the initiative which were there, they were able to achieve a control as per the current guideline to almost 20%. So that is very important. So it again says that the control is very poor in India, and this is where we need to make our guidelines and our treatment decision making simpler. So these are some of the important highlights which I will say in the current guideline which has come up last year only. The treatment goal has been simplified to just less than 130 by 80 for all subset of patient, and the clinician should work continuously with the leaders in the community and health system. This is very important, which has come up earlier. Hypertension means sent to the physician or a cardiologist, that's all. But now they have involved the role of nurse physicians, physician assistants, community leaders to increase awareness as well as improve upon the compliance, so that the hypertension and including diabetes also can be controlled in the subset of patient. And this what we call is as a multidisciplinary team based approach. The lifestyle changes we all have been emphasizing, it should be enforced, but because of our busy schedule we are not able to do it. So the role of dietitian comes very important there. The risk categorization in hypertension, we were all familiar with the PC risk category, the pool cohort equation. Since 2013 it has been working, but what we found that it is basically overestimating the score, and especially in South Asian population it was underestimating. So now they have come up with the new score which we call as a prevent score, and by that the event rate and actual rate has almost been equalized by this. And here they have changed the risk categorization to 10%. Now in prevent, if it is less than 7.5%, is considered as a low score. Home BP monitoring has been once again emphasized in the newer guidelines. The BP has been very simplified. Less than 120 by 80 normal, elevated is 120 to 129, and the diastolic should still be less than 80. Earlier it was 85. And there are just two category of hypertension: stage 1, stage 2. Stage 1 is 130 to 139, 80 to 89, and stage 2 more than 140, more than 90. Pre-hypertension term, which was very commonly used earlier, has been completely removed. So the hypertension diagnosis and labeling has been simplified to the max in the latest. This all we forget. Patient comes to our clinic, we just say, okay, check the BP, ask the nurse to check the BP, whether he's standing, sitting, whether he had a smoke, he had a tea, coffee, we don't know. And the patient comes to us with the high BP. So this is something which should be kept as a poster in front of the person who is checking the BP, and make sure that this is how it should be taken. And average of two readings. One important thing you can see here, it is an automated machine, unlike the oscillometer which or the mercury which we are using earlier. It has been completely removed. And these should be validated machines, not unvalidated ones. In home care, if you are measuring the BP, a very important point is the BP should be measured before the medicine has been taken and before the patient has taken a food and he has emptied his bladder early in the morning, and also before going to bed, not before dinner. So these are the two measurements they recommend, and they said, Ki, take these measurements for at least 3 to 7 days, and then you will be able to come. If you are not able to do it, you can go with the ambulatory BP monitoring these subset of patient and then decide. Cuffless devices, the watch-based devices, completely no. We can go with this other device which is there in the picture. This is the prevent score. I'll not go into the details. You can see here clearly the dark blue is the earlier one, PC score. That was the predicted, and the lighter one is the gray one, which is actually was happening. So PC score was overestimating, where the prevent is almost matching. Multidisciplinary, as I said, is very important. The role of physician, pharmacist, nurse practitioner, nurses, physician assistants, dietitian, community health worker, and all, they all have been given importance and they all have their own role to play. I'll not go into the details because of time constraint. Lifestyle modification, a lot of emphasis has been given to use of diet, weight, and salt. It is recommended that everybody should start encouraging potassium rich salt rather than the conventional sodium rich salt, irrespective whether you have hypertension or not. Everybody should be using it. So that has come up as a class 2A. And weight loss, try to reduce whatever is your weight by more than 5%. Dash diet with high fruit, veg, low potassium. Target is start with less than 2300, target is less than 1500. And this is how the various diets have been able to reduce the blood pressure. Almost 5 to 6 average millimeter mercury reduction is seen with each dietary modification. Exercise again is very important. And one important thing you can see here is the importance of transcendental meditation. We always earlier used to keep just casually do yoga meditation, but specifically now it has come in guidelines that it is a recommended therapy and it helps reduce the stress and the blood pressure, as well as it helps in better control of sugar, cholesterol, hypertension, cardiac disease, so many and so forth. You can just keep counting. Those are the benefits which you get. And you can read the last one, breathing control, pranayama. So these have also come in the guidelines. Treatment has been simplified to the core. Average BP more than 140 by 90, start the medication. Don't bother about it. If the patient has the blood pressure between this 130 to 139 or 80 to 89, then you check if the patient has any of these factor, either is a diabetic or a CKD or he has a clinical CVD, or if his risk score is more than 7.5, then you have to start this patient on medication. But if he is low risk, that is the risk prevent score is less than 7.5, give them 3 to 6 months of lifestyle modification. If still the BP is not controlled, start them on medication. So this is how the algorithm is very simple, so that everybody can use and practice. What drugs to be used? Every guideline comes up with the different drugs, but this is what is the current one. Thiazide, calcium channel blockers, ACE inhibitor, the first line of drug. Beta blocker is not the first line, but if somebody has a MI or a heart failure, then it becomes a first line of drug. Encourage combination pill because it improves compliance, and it has been found that 80% of people, the BP will never be controlled with a single drug. So if the blood pressure is stage 2 hypertension, start straight away with a two drug. But if it is in stage 1, start with single pill, and then you can add on the second drug with a different mechanism of action to this patient. These are the various combination which is these are the I've just given it to tell you that we never go to these levels. Look at hydrochlorothiazide. Have you ever given anybody 50 mg of HCTS? If the BP is not controlled, you can go up to that. Our maximum combination are 12.5. So just look at these. This is not OD-BD in terms of number of duration. This is how many times you need to. BD means 2 times you have to split the dose. It is not that 50-50. It is just 50 has to be given split. So I just made it. Have you ever given anybody Ramiprid 20 mg? So this is how you can go up. Perindopril 16 mg. If the blood pressure is not controlled, you can still go to up these levels. Spironolactone 100 mg. Torsemide 10 mg. Torsemide or furosemide are to be given if the patient has a CKD. eGFR is less than 30 or less than 60. In these subset of patient, instead of HCTG, you give this. Nebivolol 5 to 40 mg. Bisoprolol up to 10 mg you can give. Carvedilol 50 mg. Have you given anybody 20 mg of prazopricin or a zero point 0.8? That means two tablets three times a day. More than that, we never go to that level. But in a pregnant lady, have you ever given anybody 1000 mg of methyl dopa? The moment we give 250 mg TID, we are worried, "Arre, bahut zyada dose ho gaya." Don't worry about it. She's a pregnant lady. She needs methyl dopa. It's a safe for him. Hydralazine, you can go up to 200 mg. Minoxidil, we hardly use minoxidil. But it is a very important drug when all the drugs face, but you can still give them, but you should be worried about hirsutism. These are the combinations. I'll not go into the detail. So if the patient has secondary hypertension, when the BP is not controlled, start looking for secondary hypertension. But the most important recommendation nowadays is don't bother about looking at the potassium for identifying whether it is a primary hyperaldosteronism or not. You just screen all the adults if they are suspected to be having resistant hypertension. Of course, you need to find out the other treatable causes, like any drugs he's taking, whether he's compliant with the medicine or not, whether he has a obesity, whether he has a OSA. All those things has to be ruled out. And in a patient with pregnancy, the safe drugs are labetalol, nifedipine, methyl dopa. We know all these things, but if these things are not controlled, you can still use hydrochlorothiazide in them. So that is something which I wanted to tell you. Hydrochlorothiazide 12.5 to 50 mg can be used as a second line or a third line drug in pregnancy patient if it is not controlled. Obesity, metabolic syndrome, you if the patient is obese with BMI more than 27, GLP-1 RA can still be used as a means to not only reduce the weight but also to reduce blood pressure also. If he is more than 35, you can still recommend him a bariatric surgery to control blood pressure also, not only the weight and other associated factors. So this has been given a class 2B recommendation. Severe hypertension, nowadays we have removed the terminology called hypertensive urgency. Anybody who has a severe hypertension, we did not panic and admit him immediately, start IV drug, not required. You can just continue them on their medication at outpatient. Only if he has got a target organ damage, you need to admit them. Otherwise, they can safely be managed outside. If you give them IV, you may even cause harm. Resistant hypertension, if the patient needs more than equal to 3 drugs, and the BP to control the BP. And after controlling the BP, if the requirement is more than 4, it is called resistant hypertension. There are various factors by which you can take care of them. But the thing is, this leads to 50% higher chance of MI, stroke, and end-stage kidney. So never ignore this, and you should be very aggressive and try to give maximum tolerable dose. And if you are still not able to control, you have an option of renal denervation therapy, which has come up recently in the guidelines, which is a class 2B indication in this subset of patient. Coming to the lipid guidelines, again, the one important thing which has come up in lipid guideline is, as per the Indian scenario, there is something called extremely high risk category. We all know about low risk, moderate risk, high risk, very high risk, and this is all based on whether the patient has no risk factor, he is only a smoker. The moment you are a smoker, you come into a moderate risk category. You are a hypertension, you are moderate risk. Diabetes, you are moderate. High risk is if you have got 2 or more risk factor. Very high risk means if you are having clinical atherosclerotic coronary artery disease, or you have got more than 50% CAD in other lesion. Extremely high risk means you have recurrent events of coronary artery disease or peripheral vascular disease within 2 years. So these are the subset of patient where you need to be very aggressive. If you are low risk or moderate risk, your target LDL level is less than 80, less than 100. If you are moderate, it is less than 100 again. If you are high risk, it is less than 70. If you are very high risk, it is less than 55. And if you are extremely high risk, especially in Indian, it should be less than 40. Lifestyle modification has been given very strict importance once again here. But only thing is, don't be very fussy about the fats and all this thing. Try to tell them not to eat too much of saturated fat. Otherwise, dietary restriction of fat and all this thing doesn't cause too much of problem in these patients. They should be little liberal. Because only thing is, try to avoid ghee, which is a trans fat, and tell them not to deep fry the vegetable oils. Otherwise, these oils get denatured. So that is something which has been avoided. Trans fat should be completely avoided. And healthy fat is where you have a PUFA and MUFA in a proper ratio. N3 by N6 should be high. Exercise, very important. These are the statins, high risk, moderate risk, and low intensity statin. I'll just take 2 more minutes and should be done. It is suggested that if the lipid level is not controlled, instead of doubling the dose of statin, you try to add ezetimibe in them. So if you see here, rosuvastatin 20 to 40 if you make, or atorvastatin 40 to 80, the LDL is only reduced by 6 to 8%. But if you add ezetimibe in them, the reduction is almost double, that is 10 to 15%. So this is how you do in a stable CAD patient. Check the lipid profile. He is already atherosclerotic patient, so he has come in a high risk category. So here the lipid target should be less than 55. Start with 20 mg or atorvastatin 40. If it is not controlled in 4 weeks, add ezetimibe. Again check another 4 weeks, still not controlled. Then you can go for the third drug, that is bempedoic acid, or you can think of using PCSK9 inhibitor. In ACS, the important thing is hit hard and hit early. Again, the target is if the patient is already on lipid drugs, that it will he has achieved less than 55, just continue. If it is not continued, then give them very high dose of statin, that is 40 or 80, and check again after 4 to 6 weeks. If he is a naive patient, then add a combination of high dose statin with ezetimibe. And if within next 4 to 6 week time the lipid is not attained, then add them on these newer drugs, PCSK9 inhibitor. So in conclusion, gentlemen, newer guidelines have tried to simplify the hypertension and dyslipidemia management. Emphasis is on risk scoring, and deciding the target is very important. As per newer data, target had been revised to adjust lower is better. Lifestyle modification has once again been emphasized, and a multidisciplinary approach has been emphasized. Combination are preferred over single pills. Indian discipline necessitates a treatment for a extremely high risk category. Thank you very much.